Welcome again, Dr. Anthony Gonzalez here for another episode of Miami Community Health. Again, talking to you, our community, about health topics that are important to us. And as you may or may not know, July is Sarcoma Awareness Month. Sarcoma, what is a sarcoma? Wow, that's not, a common condition that we hear in our general public or in the media. So I brought with me a sarcoma expert from the Miami Cancer Institute at Baptist Health to talk about sarcomas with us. So today with us is Dr. Ramon Jimenez. Ramon, welcome.
Thank you, Tony. Congratulations on your program, and thank you for having me.
All righty. Well, thank you for being here. So we're going to talk about sarcoma. So first, just tell us, what is sarcoma? What is a sarcoma?
So sarcomas are a type of cancer. When you hear that word sarcoma, that is a malignant tumor. The difference is that when we usually talk about cancer, like breast cancer, colon cancer, lung cancer, anything is usually in an organ. These are cancers that are in the soft tissues, not involving the organs. So you could have, as an example, a sarcoma growing out of the fat, and that we call it liposarcoma. You can have a sarcoma growing out of the muscle. That would be a leiomyosarcoma. You have a sarcoma growing out of a bone, osteosarcoma. So those are examples of sarcomas. It's not in any organ, it's in the tissues of the body that are not organ specific.
So since we have fat and muscle and bone everywhere in our body, then we can have a sarcoma anywhere? You can have it from the top to the bottom?
You can have a sarcoma anywhere in the body. Now, there are some areas that are more common. So, for example, the majority of sarcomas are located in the lower extremity, in the leg, but specifically in the thigh. That's a really, really common area for sarcomas. The second common area is inside the belly, and those can be in the fat in the back of the belly called the retroperitoneum. Those are called retroperitoneal sarcomas, or they can be in organs in the muscle wall of, say, the stomach or the rectum or the colon, something like that.
So how common are sarcomas? Are they as common as lung cancer, breast cancer, prostate cancer?
Absolutely not. So sarcomas, when you look at the statistics, they only account for 1% of all the cancers in men and women and children. So it sums up to about 15,000 cases a year. In the entire United States, only 15,000 cases a year, compared with 250,000 cases of breast cancer a year in women alone. So there is a propensity to see sarcomas in children. In children, 15% of all malignancies are sarcoma, 15%, 1-5. And we see, for example, you might be familiar with a Ewing's sarcoma, which is a type of bone tumor that happens in children. That's called an osteosarcoma. I think people sometimes know Ted Kennedy, our senator. He had his son, Ted Kennedy Jr., who had a osteosarcoma, Ewing sarcoma in the leg, and he had his leg amputated. He's alive and well, survived all that, and a very successful person today. But you see that. At Miami Cancer Institute, I don't know if you know, we have one of our sponsoring foundations. It's called Live Like Bella.
Of course, yeah.
And yes, and Live Like Bella is a little girl here from Miami.
Yes, we know them very well.
And Bella developed a rhabdomyosarcoma, very terrible, very aggressive type of sarcoma in children. And she actually did not make it, but she had some time that we were able to provide with our current treatment options.
Yes. Yeah, we know. I know her parents very, very well. And we've been very, very involved in that foundation and supporting them through the years because we have some similarities in our families with them, not the sarcoma, but other similarities in our family. Now, you're telling us that it is definitely age is a risk factor because it's more common in the kids' sarcoma. What are the risk factors? Men, women, we talked about age, is smoking or sun, or, what predisposes you to sarcoma?
So as everything else here, things are not as usual. Let's put it that way. So when you look at age, we do see sarcomas in children, and then we see them after age 30. In that mid area there between 20 and 30, there's like a gap where you don't see so many sarcomas. There's no preference for men or women, but these are the real predisposing factors. If you've had radiation treatment in the past for something else, Commonly, people get radiation, let's say for lymphoma. They get mantle cell radiation, which is a radiation that goes in the middle of the chest and extends to the upper extremities. Uh, Radiation, as you know, is a treatment for cancer, but it can also cause cancer. And what radiation can cause are these sarcomas. We see them in that situation. We also see them in women who had breast cancer treatment, radiation there, and they get uh, a sarcoma afterwards. And so radiation is always a risk factor for sarcoma. I happen to see here, I don't know why, in Miami, people who had radiation treatment in Cuba. And apparently they use really, really strong doses there. So I've seen here multiple post-radiation sarcomas that, for instance, I did not see at my prior work setting in Connecticut. So prior radiation is a major risk factor for sarcoma. The other thing that is a risk factor is if you have a swelling in the extremity. We call that lymphedema. Why would you have a swollen extremity? Well, many reasons. But the most common reason is that somebody has taken the lymph nodes out. So for breast cancer, commonly people will get an axillary dissection. You clean out all the lymph nodes in the axilla. And then not everybody, but some people develop a swollen arm. They have lymphedema. And that chronic swelling of the arm has a predisposition to then degenerate into a sarcoma. Usually this really, really bad ones called angiosarcomas from the blood vessels and the lymphatic channels. That's one thing that we see. And not just breast cancer, sometimes for melanoma. Also, you take the lymph nodes out and you get a swollen extremity. Sometimes after trauma, if you've had an injury whereby your lymphatic systems were interrupted, you get a swollen extremity, and that can end up with sarcoma afterwards. And then one last thing, there are some inherited conditions. The most common one is called neurofibromatosis. Neurofibromatosis people know as the elephant man. It's the extreme of neurofibromatosis. So that's a gene, and neurofibromatosis 1, NF1. It's inherited dominant, and people get little nodules. You can have different levels of expression. Sometimes it's really gross, like the elephant man. Sometimes it's very subtle. But those little nodules, on occasion, can degenerate into a sarcoma also. Those are the main risk factors, I would say.
And it's funny you mentioned neurofibromatosis is because my very first patient in medical school, when they first year of medical school, they just put you interact with the patient so you can just learn how to interact with the patient, was a patient with neurofibromatosis. So
a good case.
Yeah. Well, nothing, she didn't really need anything. There was nothing to do for her. But so we learned about radiation being a risk factor, swelling in the extremities, or neurofibromatosis. So, look out for that for the risk of sarcoma. So how do you know if you have a sarcoma? Now everybody's scared, everybody's listening to you. And how do I check if I have a sarcoma on me?
Yes. So those are tough. I will tell you the problem here is that sarcomas are so rare that many times they're misdiagnosed. So a lot of physicians go through their entire practice, 30, 40 years of practice, they never see a sarcoma. And that is basically what we run into, that some people have had a lump in there, which is totally not acceptable, very suspicious for sarcoma, but it's not recognized because your doctor has never seen one. So common presentation of sarcoma, let me give you a couple of examples. People come by and tell me, Dr. Jimenez, I have this swollen thigh. And I think I know what happened. I was riding my bicycle and I took a turn and I hit myself on like the curb, and that's when it started. And the description of the mechanism of the quote unquote injury doesn't quite match what you see, the swollen thigh like that. And same thing, sometimes people say, oh, I developed a blood clot, a hematoma in my leg, and it's really not a hematoma at all. So sometimes when the patient has a finding like a swollen thigh, like so, and what they're describing that happened doesn't quite match, you got to be careful that that's not a sarcoma. The other thing that I see commonly is, people, when things grow in the belly, it's hard to pick them up.
Yeah.
And sometimes people think, I'm just getting fat. I should be careful with my diet. Even here, for instance, I've seen patients that have gone to the plastic surgeon for like a tummy tuck. And the plastic surgeon says, listen, this is not a tummy tuck situation. You're going to need to see a doctor, and so in the belly, they can get really massive and present like, abdominal girth. Your pants don't fit anymore. You feel that you're gaining weight. And that's another common presentation. But most of the time, people just have a lump in there. It's just a lump. It doesn't really cause pain, but it continues to grow. And now you're seeing it through your shirt, or now it's restricting the motion of the arm, the motion of the leg. And it's really subtle. It's totally subtle. And it's important because, there's something else called lipomas.
Yes,
and
I was just going
lipomas are super common.
Right.
And so now you listen to me and it's like, oh my God, I'm growing one. No, it's just a lipoma.
And I deal with lipomas and I see them all the time and I remove them all the time. And those, as Dr. Jimenez is saying, those are just benign growths of fat. And but can a lipoma become a sarcoma?
Tony, that comes up all the time. I don't know the answer to that. That's like the chicken and the egg. My personal opinion is that if you have a lipoma, it's always a lipoma. I don't think a lipoma turns into a sarcoma. There are, there's all kinds of nuances here. So now, as we have learned more about genetics, we have figured out that there are lipomas, and then there are liposarcomas, and then there's something in the middle. This atypical lipomatous tumors.
Yeah.
And those are like in-betweens. People sometimes call them well-differentiated liposarcomas, or sometimes people say they're just, a step above a lipoma, but not quite a sarcoma. So there's a step in between there. And we can even do a test. If you are concerned that instead of a lipoma, this is an atypical lipomatous tumor, you can send it for MDM mutation analysis. And then once they tell you that, to be a little bit more aggressive with your surgery and to follow up the patient afterwards and do all that.
Oh, interesting. Yeah. So, of course, if anything's growing rapidly, then that's more concerning, right? Totally. So if you've had a mass 4 years on your back and it's and it hasn't changed, then unlikely it's going to be a sarcoma. Okay, great.
Definitely. Rate of growth should definitely bring it to your attention. And lipomas in general grow really slowly. As you mentioned, Tony, people show up and say, Dr. Gonzalez, I have this mass for 25 years. That's not a sarcoma. Nobody who survived 25 years with a cancer in there.
Okay.
Yes.
So you have a swelling in your belly, you have a swelling in your leg. Usual testing first, what is usually done to try to diagnose it?
Yes. So usually, aside from the physical exam, on physical exam, there's like a sixth sense. When you feel a lipoma, that's like soft and it doesn't alert you. When you feel these sarcomas, they look deeper. So they are deeper in the extremity, not quite superficial. You can't quite feel them so well. And it gives you a sense that's just not a simple lipoma. So the minute you have that kind of sixth sense, things are not correct, you got to get some imaging. And the best imaging tests here for soft tissues are MRIs. So usually in the emergency room, you're not going to get an MRI, you're going to get a CAT scan. But once you get out of the emergency room, because these are elective cases, once you get out of the emergency room, we can get an MRI, which gives you the beautiful detail about all the soft tissues. You can see the muscles, you can see the fat, the nerves, you can see everything, the bone tissue, the bone marrow, the cartilage, everything, and define exactly what this is, how does it look, the relationship with other structures in the leg. That will be our first study. Most radiologists, the minute they see the appearance on MRI, it's usually a solid mass. It may have fatty components, it may have solid components intermixed, it may have an invasive border, or it may have a pushing border. But the minute the radiologists look at them, they immediately bring it to your attention in the impression, because they have a distinctive look radiographically. And that will be the first test.
Right. Okay. Then what? Then we have to get a biopsy?
Then we have to get a biopsy.
Okay.
For almost all of them.
Okay.
And a biopsy, usually in the past, we used to do a small surgery, an incisional biopsy. That's been replaced today with a core needle biopsy. So most of the time, we try not to do surgery until the very end, until it's treatment time. And so the core needle biopsies have been very good in replacing smaller surgeries that we used to do before for diagnostic purposes. Now, I will also tell you, I don't want to forget this. Some people, when they come in, what you find is that they have lung nodules. Sarcomas behave different than most other organ cancers. So instead of going to the lymph nodes like some tumors do, like for example, breast cancer goes to the lymph nodes below the arm, colon cancer to the lymph nodes in the mesentery, these sarcomas don't go to the lymph nodes at all. They basically get into the bloodstream and they get caught up in the lungs. And in the lungs, you grow little nodules here and there. So as part of the evaluation, always is critical that you get either a chest x-ray or a CAT scan of the chest to document at least that there's nothing there, or if you find something, to deal with it.
All right. So we've gone through this pathway. The patient has a mass in their leg. We find the mass on MRI. You do a true cut biopsy. You did a core biopsy. We get a sample. It comes back sarcoma. Now, you do a CAT scan of the chest and everything is negative. So the patient's got a localized tumor, a sarcoma in the thigh. Where do we go with that patient?
Yes. So,
is it amputation of the leg like we used to do?
No, don't. So we move on to treatment now. And what I will tell you is for sarcoma treatment, we use several of the same tools that we use for other cancers: surgery, radiation, and then systemic treatment like chemotherapy. But unfortunately, our systemic options for sarcoma are not optimal. So that usually the first treatment, and for some people, the whole treatment is basically surgery and radiation. Now, for surgery, let's talk about surgery first. The principles for sarcoma treatment depends on where the sarcoma is. So if it's an extremity sarcoma, as you mentioned, we want to try and do limb sparing surgery. That in the past, as you mentioned, and as the example that I brought up with Ted Kennedy Jr., we were doing amputations, and some people did well, some people did not do well. But little by little, we tried limb sparing surgery, trying to save the extremity for quality of life purposes, really, because you don't want the treatment to be worse than the disease. And sometimes losing an extremity can be a lifelong impairment. And some people never get over it. You never can regain their normal activities and all that. So in today's world, when you have an extremity sarcoma, our initial approach is to try and save the leg. That is the importance of doing all those x-rays really well. So you see where the blood vessels are, the nerves, all those critical structures that you need to save to at least have a functional or partially functional leg. Because you don't want to have a leg that doesn't work either. That's even worse. That's even worse. That's even worse. And so some of the things that we do for extremity sarcomas and to save the leg is based on giving the patient radiation first. The reason for the radiation is, so what we figured out with time is that if you just do surgery, there's a good chance that the cancer can grow back in the same place where it started, because at one point or another, you're going to run into a closed margin. There's a nerve there that you need to save, or a blood vessel. And then if you leave one cell behind, that one cell can grow the tumor right back up. So if you give radiation, what radiation does is it improves your chances of not having a local recurrence. Many people, radiation for me is always a mystery. I don't know how radiation works, but it works. Empirically, I will tell you that when you do surgery and radiation, people have less recurrences than when you do surgery alone. So surgery is a big part of treatment for sarcomas. Traditional radiation, Tony, is electron-based or photon-based radiation. That's what we always used, and it's very effective. The issue with photon radiation is that there is a little bit of bystander injury. So you can control the radiation beam very good, but not pinpoint accurate. Now, we've come a long ways since then. Now, for instance, at Miami Cancer Institute, we have the proton beam accelerator. It's a proton-based radiation. And the difference between the electron and the proton-based radiation is that the proton-based radiation, you can really pinpoint. You can really, so if to a centimeter, so let's say you're working on something right next to the spine, that spreading radiation, there would have major consequences. Use the proton beam radiation, you can stop that injury exactly where you want to, and people do better.
And the proton beam is not very common. There's like, in the state, there's not many of them, right?
Yes.
This is not like an everyday device. This is not like a CAT scan that we have at every hospital.
Correct. These are super expensive. And plus, you need a building because the machine is just enormous. Looks like a space capsule. And so we have one at Miami Cancer Institute. We're so lucky to have it. We have other ones in Florida and across the U.S., but they are in high demand because of the advantages over the traditional radiation. Absolutely.
So give the patient radiation beforehand. You do the surgery. You try to save the limb, and then, of course, does the patient sometimes need reconstruction of their leg or something like that?
So some of the surgeries for the leg, if you've lost a lot of tissue, you may need to recruit some of your colleagues in reconstructive surgery, plastic surgery, to do flap closure. Or you might need to recruit some of your friends in vascular surgery. There's a vessel in there that needs to be removed. You tried and tried and tried, could not separate it from the tumor. You have to remove that vessel, and we need to replace that vessel because we need to save the leg. And so sometimes these surgeries can be multi-specialty. I always say, the sarcomas in the belly, the retroperitoneal sarcomas, those are usually the ones that make it to the news because they tend to be giant. So every time you hear in the news, people love hear the sensationalism. We've taken out a 50-pound mass. That's a retroperitoneal sarcoma. They can get giant. And so when you're doing these surgeries in the belly, for a surgeon, you have to be at least aware that there's multiple organ systems involved, and you might get your colleagues involved, let's say from urology. The kidney needs to come out, or the ureter gets divided, and you need to bring up the bladder to rehook it up, or the colon, the rectum, anything in there that can get in the way. Because remember that the principle here is that these tumors have to be removed with negative margins. So you're not just removing the tumor, but anything that's stuck to it needs to go too. So a lot of these times you take out the mass and you see there's half of the colon in there, or one of the kidneys attached to it. And that's why these things turn out to be really big resections.
And is radiation play a role in the abdomen as well?
Yes, the radiation for the abdomen, I think, is as important as what you do for the extremity. In the belly, though, you have to be very conscientious, because this is what happens. The bowels, your intestines, they don't like radiation at all. So when you give radiation to the bowels, you can get into major trouble, something called radiation enteritis. That's like a lifelong injury that is very, very, very unpleasant. We used to see them a lot when women got radiation for cervical cancer, and they would injure all the colon and the small bowel, and they suffer forever. So what we do here is that we try to give the radiation when the mass is present. The idea being that the mass is pushing all your bowels away and protecting them. You give the radiation where you want to, and then do that. It's important because once, let's say, for example, you do the surgery first, then you can't do the radiation because you lost your window. And if you do the radiation, you push on, you're going to end up causing enteritis, and patients, they'll suffer for that.
Wow. It reminds me, you're talking about this big mass. I remember in one of my trips to Haiti, we had a gentleman that I literally took something off of his back like this big. And of course, not a sarcoma, because nobody will survive, with one of these this big. But definitely, these big tumors, and you can hide in the abdomen, and people do not know that they have them.
Because they don't cause any pain. Most of the patients come in, they don't complain of nausea or vomiting. Their bowels are moving normally. These tumors basically push all the structures around, but they don't cause a blockage, and they don't cause pain. It's just like I was telling you that my pants don't fit anymore. I could get in fatter, and comments like that. That's what people tell me, literally.
Wow.
But yeah.
All righty. So what about that unfortunate patient who comes in and, has a sarcoma, and whether it be in the extremity, and they have metastasis to the lung?
Yes.
What happens to that patient?
Yes. So usually when patients show up and they already have disease outside of the area of origin, we call that stage 4 disease. That is the most advanced presentation, let's say, for a sarcoma or any cancer, stage 4. For many cancers, once you present with stage 4 disease, or you hear stage 4, the implication is that it is terminal, that we can't cure it anymore. Well, not for sarcoma. Sarcomas, depending on your disease in the lungs, let's say you have, for example, just 2 spots or 6 spots. If the spots can be removed and there will be nothing else behind, we do that. And upwards of 40% of patients actually are cured by doing that.
Wow.
Yes, we do that. And so this is one of those special occasions where we can remove metastases for a cure. And the same applies sometimes for colon cancer, where it's metastatic to the liver. So there are and sometimes lung cancer, where it's metastatic to the brain. You can take out the brain metastasis. So those are special situations. I don't want people to generalize, because sometimes stage 4 does mean not good news. But
Right.
yeah. Yeah.
And which one do you do first? Did they get the lung first, or did they get the what's done
They,
first?
they usually, so we usually would do the primary lesion first, followed by some systemic treatment, and then leave the lungs for the very last.
Okay. And then who gets systemic treatment? Like, does everybody get systemic treatment? And let's talk about some of that systemic treatment. Remember, for our viewers, systemic treatment is the chemotherapy, the medication, what you're given intravenously that will circulate through your whole body.
Yes, yes. So for systemic treatment, I will tell you that, as I mentioned prior, we've had a lot of frustration in sarcoma, but there is one really beautiful success story, and that is the story of GIST. GIST is, those are called gastrointestinal stromal tumors, and they are special tumors that are sarcomas, but they are in the walls usually of the bowel. You can see them in the wall of the stomach, as I mentioned before. You can see them in the wall of the small intestine and the wall of the rectum, and all that, basically usually from the muscle layers. And there is a medication that was developed really to treat a form of leukemia that we actually found out that was working for these tumors called GISTs, and that's called imatinib or Gleevec. That medication is what we are always looking for, a magic bullet. That thing, number one, is a pill, so you don't have to get any IVs. People love it. You take a pill once a day, beautiful. That's the first thing. Number two, that goes straight to the tumor. It doesn't have any, barely any bystander injury, so it's directed, like the stealth bomber putting the bombs right in the one building. It's directed therapy, and then it's effective. They ran a randomized controlled trial, the American College of Surgeons. They had to stop it after a year because people who were in the placebo arm were,
Worse.
correct.
Wow.
And you could see the great benefit in the treatment arm. So they had to, for humane reason, stop the trial and move on. So we've had great success with that medication. Obviously, GISTs are not common tumors, but I would like to have a Gleevec pill for everybody. So the standard chemotherapy that we use for sarcoma, that is not GIST, it's called usually adriamycin and ifosfamide, AI. Adriamycin and ifosfamide. That is just awful chemotherapy, as bad as it gets. So it's really strong. Many people cannot tolerate it, especially older people. That's not an option. And then what I usually see is that the chemotherapy can have an initial response, but ultimately the tumors become resistant and they grow through the chemotherapy. And so we haven't had much success. We use the chemotherapy basically to shrink down the tumors. You still have to remove them. It won't finish them off. So that's one thing. The other thing is a new drug came out, one of these new biologic ones, a monoclonal antibody called olaratumab, and it came out for liposarcomas. We haven't had a new medication, chemo for liposarcomas in forever, 30 years. So when this came out, all of us were like, fireworks, beautiful. Unfortunately, so the initial studies were very promising. When they put it through the real randomized clinical trials, it didn't make it. There was no difference, and ultimately the FDA removed the medication from clinical practice. So we don't even have that medication available anymore. So we're looking for new ones. Obviously, there's always a place to improve what we're doing right now, and that's our main area.
So Gleevec only for GIST, not for extremity sarcomas, retroperitoneal sarcomas.
No.
Okay. And then who gets the chemotherapy? Everybody gets the chemotherapy? Only people with metastasis?
Only people with metastasis at this point. So you need to have, and remember that the lungs are the most common area for metastasis, but there are some special sarcomas where you will get metastasis to fat pads. You can have metastasis inside the belly, fatty areas inside the belly, or fat pads, in the mediastinum, even by the bone marrow. And anybody who has disease like that, multiple places, they're a candidate for chemo.
Okay.
Yeah.
All right. So we've learned about sarcoma. We know what it is. Now we know how to possibly find it. If you see a growth in a mass, you see rapid growth, seek care with your doctor, get an MRI. And then, of course, you lead to a biopsy. We've obviously not had great success with systemic therapy, but we've had some good success. What I'm hearing is with the proton beam with that, which saves. What is the future of sarcoma? What are some of the great things that are happening at the Miami Cancer Institute that you think will, help push this over? Of course, a rare condition. Thank God it's a rare condition, but it can be deadly. Where are we? What are the challenges, and what are the possible solutions that we're working on at Miami Cancer Institute?
I think what I mentioned before with the radiation treatment using the proton beam, especially for those retroperitoneal, the abdominal sarcomas, that has had a very, very important impact. Many of those patients, it was like an annuity. You would operate them this year, and then it comes back next year. You would operate them again, unless that's happening. I follow these patients closely every 6 months with CAT scans or MRIs, and they stay disease well controlled. And so I think the proton machine has made a great difference. I think, Tony, I'm seeing today great advances in immunotherapies. We've seen success in melanoma. We've seen success in lung cancer. We've seen success in kidney cancer. And sometimes, research takes a little bit of a lucky strike. I think we're waiting. We're post there for something to show up here in the field of immunotherapy. So my hope is either an immunotherapy or one of these targeted therapies like Gleevec, but Gleevec is targeting something called tyrosine kinase, which is an enzyme in there that phosphorylates molecules. There are other targets. We have to think outside the box here and find another actionable spot where we could cause a blockade specifically for the tumors and get a result afterwards. So I think that is actually in motion. Just like research has become so competitive that people keep it secret, so that nobody steals my ideas. But that's what's going on.
But once the ideas are out, then everybody will get to use them, and it'll benefit our patients here as well.
Yes.
Wow, great. So we've learned quite a bit today about sarcoma. Now you guys know what sarcoma is. As always, see your healthcare professional. If you notice any swelling, any mass, any rapid growth, and remember, not every lump or bump that you have is a sarcoma. So don't be fearful. Don't ruin your weekend now thinking that this is a sarcoma that you have. I want to thank Dr. Ramon Jimenez from the Miami Cancer Institute for being with us here today. And once again, thank you for listening and learning about our medical conditions on Miami Community Health. Dr. Anthony Gonzalez signing off. Thank you.
Thank you.